and be asked to further discuss the problem with genotype-phenotype correlation related to TDP-43 FUS and C9. And I will devote your attention specifically to ALS, that somehow was the engine for the discovery of those genes. As a neurologist for many decades, we consider ALS a selective disease related to vulnerability of the motor system. And for many years, we were quite facilitated in our clinical settings because we just collected the upper-lower motor neuron signs, and maybe the diagnosis of ALS was quite simple. Going through the years, according to Ellis Corial, Haley House, and so on, a critical point was to dismiss the cognitive and behavioral change in our patients. It was quite a requirement. And this was further confirmed by the inclusion, the ubiquitinated inclusion described back in '88 by Nigel Lee at King's, that somehow summarize our conception. You know, in this audience, in 2006, everything changed for what concerned the biology of two diseases. And I must say that the TDP-43 was demonstrated to be co-present with ubiquitin, both in familiar, no-SOD ALS, sporadic ALS, and non-tau frontotemporal beside FUS. And 2 years later, in 2008, the first mutation in the gene coding for TDP-43 has been described. This is part of history, nothing new. And then subsequently, families has been described carrying both patients, both sides of the coin for what concerns patient, namely patient affected by frontotemporal, patient affected by ALS in the pedigree. This was one of the first papers, but many other groups just expressed the same concept. When we analyze, firstly, the mutated patient in this country, we come out with a certain specific number of mutated patients. And looking at the different variants, we were unable to describe, firstly, patients with cognitive and or behavioral changes. But look at to this variant here. Was the same variant that has been described in Brescia, means 50 kilometers away. This family was not related to the previous one, and this patient was expressing a frontotemporal and behavioral variant. So the message is that you can have different phenotype in the same pedigrees, but at the same time you can have, for the same variant, different phenotypes. So this obviously is quite intriguing. Italy has a specific situation related to TDP-43, maybe other country has, but in Italy there is an island named Sardinia that everybody knows. In Sardinia, the number of TDP mutated is striking, is 1/3 of all familiar and sporadic cases. And in this country, my friend Adriano Chio was able to put out this evidence. But what is very intriguing is that the phenotypes of those patients is broader. In other words, extrapyramidal sign and symptoms has been described. So the phenotype of TDP-43 became really broader. Then in 2009, FUS came out, and related to FUS, we reported the first series of familiar cases with FUS mutation. And again, you see here a frontotemporal patient with the behavioral and cognitive changes. So somehow FUS was reinforcing the notion that the two diseases belong to the same chapter. And when we describe FUS, we notice that some of the patients express a specific clinical phenotypes that has been observed by other researchers. In other words, the patient sometimes can express ALS starting on the respiratory muscle or proximal muscle. But what is quite characteristic of those patients is the head drop. The head drop is quite rare in ALS patients. In a large series, head drop has been described in less than 1% of all ALS patients. So in our mind, the head drop became like a clinical signature for FUS mutation, and we share this observation with many other investigators in Australia, like in other continents. So in this very complex situation, we come out with the concept that head drop can be somehow associated with FUS in the clinical settings. Obviously, TDP and FUS were represented a biological paradigm shift, and I don't need to go further in details. I'd like to show this classification for frontotemporal dementia that was completely changed in front of us. But that has a specific implication for the clinician, not just for people at the bench. Michael Swartz, just in the back of the audience, had the privilege, it's also the honor, to put everything together and have a bunch of people in Canada say, oh, we have to make the point here. And the point is somehow spurred by the discovery of TDP-43 and FUS was where we have to face the problem of the cognitive and behavioral changes in ALS. And the statement is that 5 to 15% of our patients express FTD and ALS, but 25 to 50% of our patients express mild cognitive and/or behavioral changes. That was a major statement, tried to collect all the clinical observation together, and that has a tremendous implication in clinical settings. One implication is that we have to increase our equip in order to fully visit and fully study our patients, and part of the KIP is definitely the neuropsychologist. And this is the final product. We need to test all our patients with in a very fast way, because ALS patient can suffer for long-term evaluation. And ECAS is the last product. Sharon Abrams delivered this nice way to analyze in 30 minutes the patient, come out with behavioral and/or cognitive changes, and try to define better the patients. There is another very important implication that we have definitely to consider, namely that ALS patients with cognitive and/or behavioral changes have less survival. And this has beautifully demonstrated by Hol Hardiman, showing that when the patient definitely show selectively executive dysfunction, they live less. That has a tremendous implication for what concerns clinical trials, because obviously if you want to try something in your patient, you have to dissect the patient that has a better survival considered to the patient that has a less survival, because survival has been considered as an endpoint in many clinical trials. Obviously that had tremendous consequences, but I don't want to go in details for what concerns neuroradiology. This paper just came out in 2010, signed by Filippini. And you can see here that one of the early marker of ALS seems to be the transcallosal changes evidentiated by DTI. That was quite striking. Why transcallosal changes? And then there are many evidence for extramotor changes, both in ALS and PLS. Surprisingly, PLS, that is a disease characterized by upper motor neuron changes and no lower motor neuron changes, has more broader extramotor expression. I don't have time here to go in detail. So all the long chapter of neuroradiology, but this is a very moving, very fast-moving field, and the aim of this field is obviously to come out with some biological marker. The genotype-phenotype paradigm shift was really incredible. As a clinician, we are almost desperate in order to try to understand what is the coupling between genetics and obviously the clinical phenotype. And this slide just tried to summarize what could be the characteristic of a TDP-43 mutated patients versus the FUS mutated patients. The TDP mutated patient has an age of onset similar to classic ALS. are characterized mostly by upper limb onset, longer disease duration, cognitive changes, and sometimes, as I mentioned before, broader phenotypes. For what concerns FUS, FUS has a rapid progression and is characterized by association with frontotemporal, cognitive, or behavioral changes and hand drop signs. Okay, after saying that, let's go to the clinical arena. This is a patient that came to our institution for consultation. She's 60 years old, and she definitely has ALS. It started with respiratory problem and proximal involvement, and she didn't have ALS plus FTD. But when we observed head drop, here she was basically unable to hold the head. What I did was to require to Antonia Ratti, here is part of our genetics laboratory, obviously to test FUS. And she came out to be FUS negative. She was TDP-43 positive. Just to tell you how confusing is the situation. But I didn't tell you that she was coming from Sardinia. And obviously, we have to manage the head drop and the Sardinia origin. And at the end of the day, she came out to be TDP-43 mutated. This is just an example how to, and I try to tell you how the biological paradigm shift became really very important in the clinical settings. This is another example, very peculiar. We analyzed this patient. She was coming from Sicily, and she has been diagnosed, has affected by multiple sclerosis. She had everything according to this diagnosis, and she had also oligoclonal bands in the CSF, but for unknown reason, she developed motor neuron disease, so I decided just to look at the CSF. She had multiple bands, but at the same time, I decided to run TDP-43, and she came out to have a homozygous TDP-43 mutation. This is very unusual again, but just to tell you how very difficult is the job of a clinician that knows also about all those mutations. Let's move to C9. The situation in C9 is even more confused. First of all, the first philosophical approach that we have to take, if this is an expansion disease, obviously nobody, I think, previously can even consider ALS as an expansion disease. But this is obviously that has advantages and disadvantages. And the advantages is that we can look around, and there are many other diseases characterized by expansion, like Huntington and myotonic dystrophy. So there is a lot that we can learn. This is a very philosophical consideration, but obviously it's very important. C9 is very broad. Obviously there are the percentages of the mutated familiar frontotemporal versus familiar ALS versus sporadic frontotemporal versus sporadic ALS are broad and different according to the different population, but it's quite clear that this is the main gene implicated both in familiar and sporadic cases, both for what concern ALS and the frontotemporal dementia. So this is a major, major consideration. Today, more than 70,000 cases has been analyzed worldwide, but what is totally missing is what's going on in Asia, maybe because we don't have enough report, maybe because we don't know exactly what is the expansion of C9 in Asia, specifically in China, and what is totally missing is what is going on, obviously, in Russia so far. Now, related to C9, in the North Europe, in countries like Finland, this is very important because half of the patients are carrying SOD1 mutation, half of the patients are carrying C9 mutation. So for almost 100% of ALS patients in Finland, the reason of the disease, the pathomechanism of the disease is clear. Those are the figures related to this country. In over 44,000 samples, you see how C9 is critical in our false cases, but also in false cases. So it's unescapable for the clinician to know that over 50% of familiar cases has a specific cause, but also 11%, more than 11% of sporadic cases has a specific gene mutation. And those figures are completely in agreement with the data that has been released recently by Renton, Kyo, and Traynor. Those are the figures related to Europe, patients with the European ancestry. And you see here the percentage of C9 is little higher, just because more we go north, more we have obviously C9 related to Finland and a migration related to migrated population, and even in souls. But those are definitely critical percentages. Those spreading of genetics from familiar cases to sporadic cases raise the issue of what we mean today for familiar case. And actually, our concept of familiar cases is totally changing, and for many reasons. First of all, sometimes we don't collect enough data related to the family of the patient. Secondly, we don't collect enough data for what concerns geography, migration of the family, and so far. So we, as a clinician, we must become very sensitive, and there is a shadow, there is a green zone between familiar and obviously non-familiar cases, as indicated in this new classification that has been proposed by Orla Hardiman recently. And furthermore, according to the number of familiar of a case, how bigger is the family, obviously has an impact of a possible number of patients sporadic in the same family. So those two elements must be considered very carefully. Those are our data related to the C9 in this country. The patient carrying C9 definitely have a less survival compared to the controls, compared to the ALS patient without mutation. And we have the problem, obviously, of the ancestor. And the ancestor probably we have a common ancestor in Europe that migrated probably following the Viking horde and migrated according to the Atlantic and then Mediterranean Sea, or probably through the country and probably in North America. Obviously, we have, those are suppositions, and probably the first mutation goes back to 500 years after Christ. That means more or less at the end of the Roman Empire, just to make everything Italian, put it this way. What is the phenotype of a C9orf? Very complex. Apparently has a dominant inheritance with high penetrance, but then we have a problem of anticipation, and probably there is anticipation, but there are misleading data for suggesting or not suggesting anticipation. The C9 mutated patients have early onset, probably a more rapid disease course. The site of onset, people claim that the C9 mutated have more bulbar onset compared to the non-mutated, and the phenotype, well, the phenotype is basically characterized by cognitive impairment and very interesting associated with psychiatric features. This is very intriguing because those patients, beside having frontotemporal involvement, have hallucination, paranoid behavior, delusions, suicidal thought, and so on. But then the phenotype gets really broader according to the different report, because patients can have extrapyramidal features. Here we are debating about cortical basal syndrome, PSP, and so on, cerebellar features, and then we go further. Already has been mentioned Alzheimer's disease, and then corticobasal, and then Huntington-like patients. So it's very intriguing how everything can be explained. Try to summarize. We have patients with C9 expansion that have motor phenotype, and patients that have non-motor phenotype. And what is intriguing is definitely the appearance of psychiatric diseases possibly associated to C9 expansion. This is a very fast developing field, and obviously we have to go through all this, and as a neurologist, probably we have to talk to the psychiatrist and try to figure out what's going on there. any characteristic related to frontotemporal and ALS with expansion? Well, probably yes. The frontotemporal with expansion have a behavioral variant, more the linguistic variant. They are characterized by psychosis, anxiety, agitation, and probably faster progression. But again, delusion, hallucination, and so on. Apathy, very, very intriguing. What about the ALS? The ALS with C9 expansion have prominent cognitive and behavioral changes. They have a family history. People claim they have more bulbar onset compared to ALS patients without expansion. And here, obviously, we have different reports according to different countries. I report just this paper released by Orla Hardiman. Orla Hardiman is based in Dublin, in Ireland, so she has the advantage to have under control the population. And what is striking is the number of patients with expansion and frontotemporal, that it's quite important. But even more interesting is this algorithm, because Orla is saying that if you don't have a family history of ALS or frontotemporal, if you don't have changes, behavioral cognitive changes, your potential to have an expansion is zero. And by the other side, if you have a family history plus behavioral changes and the possibility to have an expansion is terribly increased. And what's interesting is the specificity and the sensitivity of this algorithm. As I said before, related to the frontotemporal variant, the behavioral variant seems to be more frequent on the planet related to C9orf, related to the other type. And this paper has been released by a good friend of mine, Elio Scarpini, that analyzed a certain number of behavioral variant frontotemporal, again in this country, 39 patients, and more than 30% of the patients with C9 mutation versus 8% with no C9 expansion were characterized by hallucination, delusion, aggressiveness, hypomanic status. Again, the message is that there is some psychiatric aspect in those patients. There is an issue still that we have to face, namely Alzheimer. Are the patient with Alzheimer characterized by C9 expansion? And there are different reports around the different groups. The other issue is obviously Parkinson, as I mentioned before. There are different data according to the different groups. Again, Huntington. Apparently, the Huntington disease phenocopies are in fact characterized by C9 expansion. Those are the data reviewed by Baldwin quite recently. You see the different diseases: Alzheimer, Parkinson, corticobasal, PSP, Yacob-Creutzfeldt, Huntington's-like. You see the different papers, and you can appreciate that Alzheimer's disease has probably around 1% of the patients the point is if this is the right diagnosis, but 1% of the patients are characterized by expansion of C9. So this is still an open question. Those are our data related to Alzheimer's, 0, Parkinson's, 0, CBS, 0, and PSP, 0 out of more than 100 patients that we analyzed. And also, is in more detail, the take-home message that we try to deliver is that when we have a patient that is ALS plus means ALS plus behavioral or cognitive changes, or a patient that has extrapyramidal changes, or patient that has MSA or PSP, we have to check for C9orf, because probably we have a C9orf expansion. But really intriguing, I think, for the future are the psychiatric prodromes of C9 expansion, and also the psychiatric pathology related to this expansion. And this is very an intriguing chapter that I think we have to develop in the future. Depressive pseudo-dementia has been described. There is a large number of psychoses described. There is a recent report about early onset in this lady, 30 years old, and the problem is, again, schizophrenia. I think we have to recheck early onset schizophrenia and to see if they carry C9orf or no. So you see, the genotype-phenotype question here is really compelling, and honestly, I'm very scared, and it's very complex to manage all those information that we are collecting. Going more technically, obviously, I don't have time here, and I think it's your job to go in those details, but definitely we know that the issue that we have we have to solve is the problem of a substantial variation of the repeat size according to the different areas, that probably longer repeat size in the cerebellum are associated with decreased survival. And the problem is obviously come out with exactly the number of expansion. We know that we have mosaicism, and we know that the expansion in the cerebellum are lower compared to other regions, for example, the frontal region, but we don't know exactly what that means. But the real issue, again, is come out with the number of expansion. And here, I think many laboratories around the world are trying to optimize and come out with the number, exactly the number. We have a different technology, repeat primer PCR with amplicon length analysis, but then the real problem is the southern, and we need to modify our strategy. And recently, we just come out with this paper just summarizing the fact that when Peter Anderson delivered to 14 different laboratories the same sample in order to define the number of repeat. There is a quite of sharing, but there was also discordances. And the conclusion was, in fact, that in order to come out with the right numbers and try to define the amplification, we need to probably to run RP-PCR and amplicon length analysis. But in specific cases, we need to go to the southern blot, and we have to optimize our southern blot in order to have exactly the numbers. I was thinking a couple nights ago that probably the different mechanism of disease can have also impact on the different clinical phenotype. So this is to your consideration. There are a couple of questions still on the table, namely that we have some of our patients are carrying double mutation. Double mutation means they are carrying C9 mutation plus something, and we have a double mutated here. We report the TDP-43, for example. So what is the meaning of double mutation? And the other very intriguing question is that when we run the C9orf in our controls, we come out with all 17% of our controls carrying expansion. That means that in Italy, that count 60 million people, we have 100,000 people with potentially expansion. So this is probably a health problem in this country like in any other country, because the question is how many of those expanded will eventually develop neurological disease. So this is very complex, and those three genes, as said before, somehow are supported by overlapping pathology, because we know that all three of the genes are supported, at least in ALS, by TDP-43 inclusion, except in SOD1 and FUS mutated. For what concerns frontotemporal, almost to 50% of the patient are carrying TDP-43 inclusion, except FUS and except, obviously, tau mutated. So if this is the case, probably TDP-43 is the common mechanism of disease, and this has been used recently with BRAC. Obviously, you know BRAC. BRAC was able to make the staging in Parkinson, Alzheimer, Huntington, and now in ALS. He reported 80 cases. This is a cross-sectional analysis of the inclusion of phosphorylated TDP-43 in different regions according to the different patients. This paper raised a lot of criticism because obviously this is not just a longitudinal study of a single patient, but it's a trans analysis of different patients. But anyway, Brack define that stage 1 is characterized by TDP-43 inclusion in the cortical motor area and in the motor neuron. So the disease starts both in the upper lower motor neuron. In stage 2, the disease diffuse in the frontal area and in the extrapyramidal area, but also in unexpected area in the brainstem, like olivary nuclei and so on. The stage 3 is characterized by further expression of TDP-43, and stage 4 even in the amygdala in the hippocampal area. And apparently, C9 is amplifying the burden in those specific regions. We don't know if this is true, but I think this is provocative. We have to start to think in those terms. Those are the figures, and specifically, Brack believed that TDP-43 is migrating along the axon that is responsible for the diffusion of the disease, and inclusion has been reported also in oligodendroglial cells. So oligodendroglial cells became really a player in this disease. Obviously, we have to rethink to all the data related to neuroimaging, because obviously all the data in DTI probably have to be considered according, if the Brack is true. We need to reconsider all those data. Brack is also looking at the opposite, namely what is the diffusion of the TDP-43 phosphorylated in frontotemporal, obviously non-tau, and according to the different color, the yellow, this is stage number 1, and here there is the migration in the back, but there is a coincidence inclusion also in motor neurons. So here we are trying to make if this is true, obviously we can consider very broad the phenotype of both disease. In other words, we need to look at for motor neuron involvement in frontotemporal dementia patient, and we need to look at cognitive behavioral changes in our ALS patients. So to try to reach the end, I think that it's critical today for the clinician to come out with an algorithm obviously of genetic testing. That means that in false, definitely C9 is number 1. And obviously according to the regions, the migration, the family, we need to test SOD, but I didn't mention because it's not part of the game here, but could be part of the game. We need to test TDP and FUS. But for what concerns souls, if souls are carrying dementia, again, we have to check C9. And if SOLS is related to specific geographic area, at least in this country, if a patient is coming from Sardinia, TDP-43 need to be checked. Again, because 1/3 of the patient coming from Sardinia are carrying definitely a mutation. Obviously, this is an algorithm, we can say May 2014, our personal algorithm. You can share this algorithm or no, but at least we have to try to do something, because otherwise we miss the patients. This beautiful slide has been recently released by Eisen, and Eisen just summarized that when the patient just come to our attention, many things happen before. There is a pre-symptomatic status and a preclinical stage. Obviously here we have incredible possibility to define the preclinical stages and to define the carriers of the different mutation. And this is a very important step forward, because we can obviously look at on those carriers the development eventually of biomarkers, CSF biomarkers or plasma biomarker or so on. And finally, obviously, all what I said means that we have a therapeutical paradigm shift, because here we have 3 genes that are probably acting in a possible overlapping way, and obviously we have a C9 information of an expansion, and definitely we have to try to develop therapies against its expansion. Again, here we have definitely the patient, we have these 3 genes that are very important. We don't have sometimes time to go in the bench, because the patient desperately asking for therapies, and probably we have to subgroup our patient. At least in the future, we have definitely we have to try to define and subgroup our patients. And at the end of the day, the paradigm shift was complete, because we have this journal dedicated to ALS, but in 2012 changed completely the title, just to tell you how important has been the discovery of TDP-43 and obviously of C9 and FUS. Thank you very much.